Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and good evening, everyone. So welcome to the first session of the new series of Navigate Medico CME program. This is with the neurology division. We are starting with topic management of Parkinsonism disorders. So to begin with today's program, I would like to welcome Secretary of National Academy of Medical Sciences, Professor Umesh Kapil sir, for the welcome address to the delegates and participants. Sir, please.
Namaskar to all the participants. Namaskar to faculty members who have joined. It's an humble effort of National Academy of Medical Sciences to start the online CME program on different themes. This is the 42nd lecture which has been organized. If you look at the background of this Navigate program is that what we are trying to do, there's 100,000 MBBS students come out every year. And out of that 100,000, about 6,000 to 7,000 get into the MD MS program, and 6,000 to 8,000 get into the DNB program. Rest of about 80,000 plus, they want to do post-graduation, but they don't have any facilities. Sometimes what happens, they're doing house job, or they join in as a medical officer, but in the heart of their heart, they would like to do post-graduation. So what NAMS thought in its wisdom, that if we are able to get these MBBS students who would like to do post-graduation, number one, or those who are doing post-graduation. Now, if we can teach them with the most eminent faculty members of our country, then they would emulate it. Because normally what happens is they don't get a chance to update their knowledge. The only chance or center which they have is these MD, MS coaching centers, and which they have their own limitations. So what we have done, that during last 4 months, we have developed and we have requested the most eminent faculty members in our country. Like we had Dr. Mohan from Diabetes Research Center, we had many other scientists who came and gave them practical tips about the subject which they are talking about. Now that's number one. And number two is that we have kept the session for 2 hours. so that about 15 minutes to 1 hour, the speaker can talk about the subject, and then subsequently we can also have question answer session and maybe some assessment, so that the people are attending and they are responding and asking the questions, and they are also giving the assessment that how much they have learned about. Now, this is something, a brief background about the Navigate program, and we are most grateful to Dr. Jaswant and Dr. Preeti from All India Institute of Medical Sciences Psychiatry Department, who have been facilitating this program right from the beginning. They are so helpful, and there's no, this is just an honorary service they are doing for the NAMS. Now, today we have with us Dr. Rupa Ranjan, who is an Associate Professor in Department of Neurology at AIIMS, and she will be introduced by Dr. Jaswant. I understand Dr. Padma has been called in the Ministry of Health for an urgent meeting, so she will be joining at about 5 o'clock. And Dr. Shadeen would also be joining shortly. So with these few words, I again welcome all of you, and please, those who have done their MD with 5 publications, they should join National Academy of Medical Sciences family by becoming member. Those who have done MCH or DM, they can join us as associate fellow, and those who are senior professors, they can join as a fellow. So these are some of the things, our avenues which are available, and all of you are requested, those who are interested, they may organize a CME, continuing medical education, in your own institution. We provide about 100,000 rupees for organizing the CME, and there's no much what you call babugiri or official obstacles. We are very prompt in issuing the funds. We have a protocol. If you follow the SOP, and then we expect that the NAM's name would help you to generate funds from the ICMR, DBT, DST, and other organizations. You can charge your own registration fees. That's fine. Also, what we have, I must share with you, that we have a young scientist exchange program. Suppose you have, say, we find that Dr. Srinivas has a young student and he wants to send his PG to All India Institute of Medical Sciences, Delhi. We will cover his travel, we will cover his per diem, place of stay, and so forth. Plus, what we need is that the letter of acceptance should be there with the person who is being deputed. So a scientist should be deputed from his own institution, and the host institution should accept it. That is what we request. Now, this is something very important, and this is a young scientist exchange program which can lead to learning of the new skills. I understand there are some very good facilities which are available at All India Institute of Medical Sciences, New Delhi, or AIIMS Rishikesh, or AIIMS Jodhpur, or many other AIIMS. So please submit and depute the young scientist for the young scientist exchange program. So these are some of the part of the welcome, and thank you again. And over to you, Dr. Jaswant, to carry forward the proceedings. Thank you.
Yeah, thank you. Thank you very much, sir, for the kind words. Like, even we feel honored to be associated
Yes,
with
one.
medical
Sorry
sciences.
to disturb. Yes, one. Can I disturb you? I think Dr. Kapil, the question is going to be directed towards Dr. Kapil. Good evening, sir. I'm Dr. Kim.
Good evening, ma'am.
Dr. Kapil.
And please We can talk on.
Sir, I just wanted one clarification. Those those scientists, it has to be only in AIMS or it can also be any other institute?
go
Because you
anywhere.
were mentioning specifically
can
only
go-
AIMS.
Ma'am, they can go anywhere. AIMS, I just
Yeah, I think you
Yeah,
must
so-
emphasize on that.
Okay.
Any institute,
So
not just only AIMS,
they must
right?
go to
It
PGI
sounds as
country.
if you are just monopolizing with the AIMS.
I agree with you
Thank
totally.
you.
My apologies. So again, I clarify, they can go to any institution in the country. They can go to Tata Institute, Tata Institute of Fundamental Research. They do Tata Memorial Hospital. They can go to PGI Chandigarh. They can go to SGPGI Lucknow. Any institution. So my sincere apologies for talking about mainly from AIMS. It's some bad loyalty which I have because I worked there for 40 years. So, but please, I'm stand corrected. They can go to any institution which has expertise, and our student and scientists can learn. That's all. Thank you very much. Over to you. Sorry for interruption, Dr. Jaswant.
Thank you, sir. So, continuing with this current session, I would like to welcome Dr. Rupa Rajan. She is currently working as Associate Professor in the Department of Neurology at AIMS, New Delhi. Her special interests are movement disorders, electrophysiology, and genetics of tremors, dystonia, Parkinson's disease, deep brain stimulation. She has more than 100 publications and her index is 13. She has been awarded and honored with as a co-chair of the International MDS Task Force on the Management of Movement Disorders, Integrated and Interdisciplinary Care, steering committee member of the Young Member Group and member education committee of and also she's a member of a Tremor Study Group. She is also a member of International Movement Disorder Society LEAP program class of 2019. Ma'am has been selected for DPT Welcome Trust India Alliance Clinical Public Health Fellowship 2023. Ma'am has also been awarded with Early Career Research Award from DST SERB 2016. So personally, I have seen ma'am working and fully dedicated towards Parkinson's disease and treating patients of movement disorders. So now I welcome Rupa Rajan ma'am, and I would also like to hand over the session to ma'am, please.
Thank you, Dr. Jaswant. Thank you, Dr. Jaswant, for that very kind introduction. At the outset, I would like to thank the organizers and Professor Kapil for this very wonderful opportunity to talk to you all today. I am Dr. Rupa from the All India Institute of Medical Sciences, New Delhi. I hope my screen is visible.
Yes, ma'am.
Thank you. So the topic allotted to me today is an approach to Parkinsonian syndromes. So it's a topic very close to my heart, and I'm very happy to share over the next 30 to 40 minutes how we approach this clinical problem. And this talk will mainly be about the clinical approach and diagnosis to Parkinsonism. I do not have any relevant disclosures for this talk. I request you not to please kindly not record or photograph the patient videos that we will see throughout this lecture. So this is the brief outline of what we will go through in the next 40 or so minutes. I would like to tell you what is Parkinsonism, and then we will speak a little bit about Parkinson's disease and how it is different from Parkinsonism. We will also touch upon atypical Parkinsonism, and then we will wind up with some investigations that one may consider doing in a patient with Parkinsonism. So at the outset, this concept is very important to understand that Parkinsonism is different from Parkinson's disease. Parkinsonism is basically a symptom complex. So whenever a person has a bradykinesia, which is a slowness of movement, rigidity, which is a form of increased tone in the limbs, and rest tremor, some combinations of these three symptoms, with or without gait impairment or postural instability, we would call this as Parkinsonism. So these findings should be very demonstrable very clearly on clinical examination, and it should not be due to confounding factors. For example, if you have a stroke and following which you have spasticity, you may have some pseudo-bradykinesia, where there is no true decrement or true slowness in movement, but it looks like a bradykinesia. So true bradykinesia with usually lead pipe rigidity and a particular type of rest tremor. These are the features of Parkinsonism. So among these four core symptoms, bradykinesia is the most important. To define Parkinsonism, one has to demonstrate that there is bradykinesia. How do we do that? We will see later. And in addition to that, patients should have 2 out of the other 3 features, or at least this was the initial earlier classification, and according to the current consensus for Parkinsonism, you should have bradykinesia with either lead pipe rigidity or a 4 to 6 hertz rest tremor. Postural instability, because most patients with Parkinson's disease don't initially present with falls or postural instability. This has been for the criteria for Parkinson's disease. This is considered it is not now considered for the criteria of Parkinsonism. So to understand, we should demonstrate bradykinesia along with rigidity or rest tremor to say that a person has Parkinsonism. So how do we look for bradykinesia? Bradykinesia is slowness in movement and a decrement in the amplitude or the speed of movement. So we assess this by looking at repetitive movements. So you can see this young woman here in whom we are looking for bradykinesia by asking her to do repetitive hand movements. It can be either finger tapping or hand movements or any rapid alternating movements of the hand. And you can see that those movements are very slow, and although they start off with a certain good amplitude, as the movement goes on, you can see that the amplitude reduces and the speed also reduces, and intermittently she may have some pause in the movement. So these are what you look for in bradykinesia. There is a decrement in the amplitude and there is a reduction in the speed of the movement, and in between there are pauses. So this is how you demonstrate bradykinesia. So we talked about pseudobradykinesia. Sometimes due to other features like spasticity or stiffness, musculoskeletal deformities, one may have slow movements. This has to be distinguished from the true decremental in amplitude and speed, which is known as bradykinesia. So after bradykinesia, on examination, one should look for rigidity. So in Parkinsonism, usually we will find a lead pipe rigidity where the rigidity is same throughout the movement at the beginning and throughout and till the end of the movement, it remains the same. This is in opposition to a clasp knife kind of stiffness that you feel when you look at a patient with spasticity. Here you will feel the resistance throughout the range of movement, and it is velocity independent. Whether you do make these movements, flexion, extension, or rotational movements at the wrist, whether you make it fast or slow, the stiffness or the resistance you feel will remain the same throughout. And isolated cogwheeling is not enough to qualify for rigidity, because many patients with tremor, any kinds of tremor, if you test for rigidity, you may feel a cogwheeling. And that is not enough for us to consider as rigidity in the context of Parkinsonism. Then the most famous or one of the common symptoms of Parkinsonism or Parkinson's disease is a rest tremor. So this is the typical rest tremor that one would see in a patient with Parkinson's disease. This is usually 4 to 6 hertz rest tremor. And it is also known that some patients may have, in addition to the rest tremor, may have a kinetic or a postural tremor in Parkinson's disease. That means an action tremor, not while the limbs are at complete rest, but while doing actions or holding it up against the gravity, the tremor may occur. And that particularly a type of tremor known as re-emergent tremor is suggestive of Parkinsonism or Parkinson's disease. In re-emergent tremor, what we mean is that a patient may have a rest tremor, and when he puts out the arm, he or she puts out the arm to maintain a posture against gravity, initially for a few seconds, the tremor will not be there, and then it reappears at the same frequency as the rest tremor. This is known as a re-emergent tremor. So here we see typical rest tremor in Parkinson's disease. So, and the fourth feature that one may use to diagnose Parkinsonism is postural instability. How do we test for postural instability? We look for test for postural instability by looking at doing the pull test. So this is what we call a pull test. So on history, one may elicit the history of falls or a slow gait. But on examination, one can do a pull test. And this is basically you stand behind the patient, and after warning them that you're going to give them a pull towards the back, you give them a subtle pull on the shoulders. Make sure that you have a wall or something behind you so that you can, the patient doesn't fall. And normally people don't lose balance, and they are able to correct themselves and don't take more than 2 steps to maintain their balance. But if someone takes more than 2 steps to regain their balance, or if they fall, then that would be considered a positive pull test or postural instability. So these are the core features of Parkinsonism. Once again, to revise, we saw how to look for bradykinesia, how to look for rigidity, the rest tremor, and postural instability. And these features one has to elicit in history as slowness in movements, as tremor, as stiffness in the limbs, and as falls or a typical Parkinsonian gait, where the gait becomes slow, the steps are short, there is a shuffling gait with a tendency sometimes to run forwards, rush forwards, known as festination. And occasionally patients may develop something called freezing of gait, where they feel that the feet are stuck to the ground and are unable to move forward. So these are the classical typical features of a Parkinsonian gait, which one can ask for in the history and confirm in the examination. And so if you demonstrate bradykinesia with either rigidity or rest tremor or postural instability, we would say that the person has Parkinsonism. So once we have a patient with Parkinsonism, then the most important question in the mind of the clinician is, what is the cause of this Parkinsonism? Am I dealing with Parkinson's disease, or is it an atypical Parkinsonism? So Parkinson's disease is what we call a typical Parkinsonism. It is the most common cause of Parkinsonism, and it has certain features which helps us recognize this in the clinic. So we know that Parkinson's disease is the second most common neurodegenerative disorder in adults over the age of 60 years. The lifetime risk of developing Parkinson's disease is about 2% for men and about slightly less at 1.3% for women. And in India, it is estimated that there will be about 0.7 million people with Parkinson's disease by the year 2030. It is a disease whose prevalence is rapidly increasing. In 1990, worldwide, there were about 2.5 million patients with Parkinson's disease. And in 2016, this is about 6.1 million. And about nearly a tenth of these patients are expected to be living in India by 2030. So this is definitely a disease that as a clinician, we all should be familiar with. So Parkinson's disease is an insidious onset progressive disease, which is characterized by an asymmetrical Parkinsonism. So patients tend to develop this rest tremor, slowness, and stiffness on one side initially. And usually most patients have a rest tremor, and it is characterized by a good and sustained response to levodopa. And they do not have some certain features that we look out for in patients for Parkinsonism, such as eye signs, slowness of eye movement, which we will see in a short while. They don't usually have, they don't have any ataxia or cortical sensory loss or apraxia. Usually the features such as gait dysfunction or falls, memory impairment, cognitive dysfunction, and autonomic dysfunction in the form of bladder involvement, orthostatic hypotension, these happen very late in the course of Parkinson's disease, generally after in the second decade of Parkinson's disease, and definitely not earlier than 3 to 5 years. So this is a typical syndrome of Parkinson's disease, an insidious onset progressive disease characterized by an asymmetrical Parkinsonism with rest tremor and a good response to levodopa without any atypical features like ataxia, higher cortical dysfunction, apraxia or absent eye signs, and without any early falls, early cognitive involvement or autonomic dysfunction. So how do we diagnose Parkinson's disease? Parkinson's disease is diagnosed using clinical criteria. So this is the most important takeaway from any lecture on Parkinsonism, is that to diagnose this, one has to examine the patient, elicit the history, and confirm these findings. And it is a clinical diagnosis as of now. So first step is to define Parkinsonism. It is to demonstrate that the patient does have indeed bradykinesia plus either rigidity or rest tremor. And then to diagnose a clinically established PD, as according to the Movement Disorder Society clinical criteria for Parkinson's disease, we have to look at these few features, some of which are absolute exclusion criteria for Parkinson's disease, some of which are red flags, and some are supportive criteria. So the absolute exclusion criteria include cerebellar signs, supranuclear gaze palsy, which suggests a form of atypical Parkinsonism called progressive supranuclear palsy. If you have an established diagnosis of severe cognitive dysfunction, which is characteristic of a frontotemporal dementia, behavioral variant frontotemporal dementia. If you have only Parkinsonism restricted to the lower limbs for more than 3 years, only a predominant lower body Parkinsonism. If the patient is on treatment with anti-dopaminergic or dopamine depleting agents, that is dopamine receptor blockers, if there is a lack of response to levodopa. So this levodopa response, we have to assess at adequate doses. So levodopa is generally given in combination with either carbidopa or benserazide at a ratio of 1:4. So for 100 milligrams of levodopa, 25 milligrams of carbidopa or benserazide. And this is so as to block the peripheral decarboxylase, and so that these levodopa can reach the brain. And with a good dose of levodopa, to assess, to say that somebody has no response, one should ideally test up to at least 800 to 1000 milligrams of levodopa for 3 months, depending on slowly titrating up to these doses or up to the maximal tolerated dose for the patient. And even after that, if there is no improvement in stiffness, slowness, bradykinesia, rigidity, or rest tremor, then one may consider that this is a lack of response to levodopa. And then sensory symptoms such as cortical sensory loss. So this again suggests one of the forms of atypical Parkinsonism, where you may get cortical sensory impairment, that is impaired some things like glasphesthesia, inability to identify what is written on the hand. You may have sensory inattention. When you give 2 sensory stimuli on both hands, they tend to ignore or neglect one side. Alien limb, or apraxia, which is apraxia is it is an inability to do trained activities that which we have learned, such as brushing, changing clothes, combing hair. So although there is no motor weakness, sensory loss, ataxia, or another deficit that can explain this difficulty in performing this act, patients are unable to do these trained movements, and that is known as apraxia. So absence of these, if these are present, this is a exclusion criteria for Parkinson's disease. If you do a dopamine functional imaging, we will see some of those later. You can do, there are certain PET and SPECT tracers that can bind to the presynaptic dopamine active transporters in the substantia nigral neurons. And any dopamine, if these scans don't show a deficiency of dopamine or presynaptic dopaminic deficiency, then it is very unlikely to be Parkinson's disease. And if you have another reason for this Parkinsonism, such as drug-induced Parkinsonism or any structural lesion in the basal ganglia, which may sometimes present with Parkinsonism, these are absolute exclusion criteria. Now, there are certain features which are red flags, which may be sometimes present in some patients with Parkinson's disease, but are usually rare. And if these red flags are present, to make a diagnosis of a probable Parkinson's disease, you should also have some supportive criteria, which are listed in the next box. So these red flags include a rapid deterioration of gait, like we said earlier, early falls, especially falls occurring within 3 years of onset of Parkinsonism. And if you don't have any progression in symptoms over 5 years, that suggests that this may be may not be Parkinson's disease, which is a gradually progressive disease. We do expect some progression in symptoms over the years. If you have early bulbar dysfunction like dysarthria, dysphagia, if there is respiratory dysfunction, early severe autonomic failure, if there are early falls, recurrent falls due to imbalance, if there are disproportionate anterocollis, that means an abnormal posturing of the head, disproportionate anterior flexion of the head, which suggests a dystonia, which is usually not very common in typical Parkinson's disease, but is much more common in one of the atypical Parkinsonisms that we will see in a short while. And if you have pyramidal tract signs like spasticity, brisk reflexes, and if it is symmetrical at onset. So these are red flags By that, I mean, it does not an absolute exclusion. Many patients with, for example, young onset Parkinson's disease, they may present with a symmetrical bradykinesia, symmetrical rigidity. But if these are there and there is no rest tremor, it's a symmetrical presentation, then one should also look for some of the supportive criteria. Supportive criteria include a clear and dramatic positive response to dopaminergic therapy. Parkinson's disease usually responds very well to even low doses of levodopa. If patients develop levodopa-induced dyskinesias, by this I mean patients with Parkinson's disease initially respond very well to medications, but as the years pass by, they develop what we call motor complications of Parkinson's disease or motor complications of levodopa therapy, by which they develop wearing off of the effect of medication. So the same medication, one dose which used to last for say 5-6 hours, 7 to 8 hours, slowly the effect starts becoming shorter, and some patients develop abnormal involuntary movements associated with levodopa doses. So these abnormal dance-like movements are called dyskinesias. And the presence of dyskinesias, which happens as the disease progresses, is considered a supportive criteria in favor of Parkinson's disease. Rest tremor, if it is present, again strongly suggests Parkinson's disease. And if you have a positive diagnostic test of olfactory loss, that is hyposmia. Hyposmia is a very common non-motor symptom. It can be a premotor symptom. Before the onset of Parkinson's disease, patients may have hyposmia in the decades prior to Parkinson's disease. So if you can demonstrate an olfactory loss or cardiac sympathetic denervation on MIBG scintigraphy, these are again can be used as supportive criteria for a diagnosis of Parkinson's disease. So these criteria, if you employ this criteria, the specificity for diagnosis is usually at least 90% for clinically established Parkinson's disease. So just to summarize, this is the MDS clinical diagnostic criteria for Parkinson's disease. One has to demonstrate Parkinsonism. To say that it is established Parkinson's disease, you should not have any exclusion criteria. You should have at least 2 supportive criteria and no red flags. And for clinically probable PD, again, no exclusion criteria should be there. And if you have any red flags, which should be less than 2 in number, you should have an equal amount of supportive criteria. So this, although these are very well laid out in the clinic, these can come as checklists. You can do that, but these are also concepts that as a clinician, this should be in your decision making when you see a patient with Parkinsonism, whether these boxes are filled or whether the patient's clinical features match this. And then with practice, this can be part of your clinical examination tailored to achieve this diagnosis. So there is also now a concept of prodromal PD, because sometimes patients may come to your clinic with very, very early signs, or sometimes someone may come saying that their relative or father, mother has Parkinson's disease. What is their chance of developing Parkinson's disease? This is a question that cannot be answered very easily. But these days, we know now that PD has a very long prodromal period. There is a very long pre-symptomatic period, then a prodromal period, and then it becomes clinical Parkinson's disease. By the time the motor symptoms of Parkinson's disease manifest, about 70 to 80% of substantia nigra neurons are already lost. So there is a huge benefit in trying to identify the early patients, especially from the point of view of trials for disease-modifying therapies. One of the reasons that we don't have a disease-modifying therapy for PD, one of the reasons is thought to be that we are identifying patients very late, and already the degeneration has advanced to a point where disease-modifying therapies are no more helpful to them. So this is one effort towards identifying the early or the prodromal patients who have some symptoms. And so looking at symptoms such as prodromal markers such as REM behavioral disorder, which is a sleep disorder in which patients lose the atonia that is associated with REM sleep, and they start acting out, enacting their dreams, speaking out in the sleep. Then the dopaminergic imaging, or mild Parkinsonian signs, hyposmia or loss of olfaction, constipation, orthostatic hypotension, urinary dysfunction, anxiety, depression. So these are some non-motor or pre-motor symptoms associated with Parkinson's disease. So a combination of these symptoms and some risk markers, such as the gender, pesticide exposure, solvent exposure, caffeine or coffee drinking is supposed to be protective for Parkinson's disease. Smoking, again, reduces the risk of Parkinson's disease in many observational studies, but it increases the risk of many other diseases. So that may not be a very solid way to reduce the risk of PD. Positive family history. If you have a genetic test and carry a known mutation for Parkinson's disease, so these features can be incorporated into a prodromal PD calculator, and that can tell you the post-test probability of whether someone is suffering from prodromal Parkinson's disease or not. So this is one of the ways to identify early prodromal Parkinson's. Then we talked so far about the motor symptoms and signs of Parkinson's disease. This is because this PD as a syndrome is defined by the motor symptoms, but there are a host of non-motor symptoms in Parkinson's disease, which are very important to pick up in the clinic, because they need to be treated for you to improve the overall quality of life of the patient. So some of these symptoms, especially hyposmia, decrease in smell, anxiety or depression, and REM behavioral disorder and constipation. These four especially can be pre-motor symptoms, before the motor symptoms come. And after along with the onset or throughout the course of Parkinson's disease, patients may develop other symptoms like neuropsychiatric issues like depression, hallucinations, autonomic dysfunction. Usually occurs late in Parkinson's disease, but can involve the bladder, orthostatic hypotension. Then they may develop cognitive impairment, usually executive dysfunction, and a difficulty with recent and working memory requiring tasks. Sometimes patients can have sleep problems like REM behavioral disorder, restless leg syndrome. There is also another host of neurobehavioral symptoms that that are known as impulse control disorders. So these are a particular type of non-motor symptom in Parkinson's disease, in which patients have an irresistible urge to perform pleasurable activities, like you can have pathological gambling or compulsive shopping, hypersexuality, compulsive eating. So these may sometimes be a side effect of medications used to treat Parkinson's disease, and these have to be screened for. So a whole host of non-motor symptoms also occur in Parkinson's disease. So with that was a brief introduction into Parkinson's disease. And having understood what is Parkinson's disease, now we can then talk about what is not Parkinson's disease. So there are patients with Parkinsonism who have certain atypical features that meet the red flags meet the red flags for Parkinson's disease. So these are patients we call as having atypical Parkinsonism. So atypical Parkinsonism also, there is a huge list of causes, but for the sake of simplicity, one can consider it as a major chunk of them are again degenerative. Like PD is a degenerative disease, you have these degenerative atypical Parkinsonisms. Then you may also have patients with vascular Parkinsonisms, those who have long-standing hypertension, diabetes present with the small vessel microangiopathic changes in the brain and a particular type of Parkinsonism. You have drug-induced Parkinsonism. You may have sometimes diseases like normal pressure hydrocephalus that can mimic Parkinsonism. They present with a lower body predominant Parkinsonism. And there are a whole host of hereditary disorders that can result in, for example, neurodegeneration with brain iron accumulation, or juvenile Huntington's disease, or Wilson's disease. All of them may present with Parkinsonism. So among the degenerative atypical Parkinsonisms, these are the four classical degenerative atypical Parkinsonisms: progressive supranuclear palsy, corticobasal degeneration, multiple system atrophy, and dementia with Lewy bodies. So progressive supranuclear palsy is a 4-hour tauopathy, which is characterized by an akinetic rigid Parkinsonism. That means they don't usually have rest tremor, and they have a very prominent vertical supranuclear palsy, gaze palsy, which is most prominent for the down gaze usually. And they have very early falls, especially backward falls, and a very particular staring look. They may also have some upper facial dystonia, called the procerus sign or the omega sign. This upper procerus muscle may be very hyperactive. They may sometimes have an applause sign. So if you ask the patient to clap, say 3 times, you clap 3 times and ask the patient to repeat, they will not be able to stop at 3. They may continue clapping. So there is an applause sign. And there is a poor response to levodopa, except for some types of PSP, they may have a poor response to, they usually have a very poor response to levodopa. So if we look at these videos, you can see this 48-year-old lady with slowness of activities for the last 3 years and gait difficulty with recurrent fall for the last 2 years. So you can see that it's a very different phenotype from what we saw in the lady with rest tremor. She has very significant difficulty in walking. You can look at a very staring look. There is no tremor. She is a significant imbalance. You can see that very prominent staring look with that upper facial dystonia, what we call an omega sign. And if you look at the eye examination, you have to look very carefully for the eye in all patients who present with Parkinsonism. You can see that the horizontal eye movements are okay, but the vertical eye movements are restricted. You can see that the up gaze is restricted, and so is the down gaze. She can hardly look down. So this is a very characteristic feature of progressive supranuclear palsy. If you do an MRI, you can see midbrain atrophy. So this white arrow points towards the midbrain. The pons is okay, but you can see here midbrain atrophy in both this is been known as many in many names, like the hummingbird sign, the Mickey Mouse sign. You can see those, imagine those in their MRI there. So this is progressive supranuclear palsy. And again, there are criteria for the diagnosis of this disease. It is the sporadic illness, usually age onset more than 40 years, progressive. And the criteria for this basically scores the ocular motor dysfunction, the postural instability, the bradykinesia, and the cognition. And depending on how far severely affected these are, we have can make a diagnosis of a probable PSP or a possible PSP, like that. So we already saw this imaging. The next atypical Parkinsonism, which is again a tauopathy, is corticobasal degeneration. So corticobasal syndrome is actually the clinical syndrome, clinical picture. Corticobasal syndrome, the commonest cause may be CBD. The underlying pathology may be a corticobasal degeneration, but we now know that even patients with an underlying PSP pathology may also present with a corticobasal syndrome. So they may have a predominant motor or a cognitive phenotypes, but they usually have a combination of both, and they can be quite, maybe sometimes rapidly progressive. So for CBD also there are different criteria. So basically for a probable corticobasal syndrome, we usually have an asymmetrical Parkinsonism with asymmetrical rigidity and kinesia, dystonia or abnormal posturing in the limbs. You may have myoclonus in the limbs, plus at least 2 of either buccal or limb apraxia, a cortical sensory deficit, or an alien limb phenomenon. So we'll see some of these in this next video. And so that is the prototypical corticobasal syndrome. You may also have CBD, which presents with frontotemporal dementia. So they will be diagnosed as having a frontal behavioral spatial variant, FBS CBD, or a non-fluent or a variance of language disturbance like primary progressive aphasia. And sometimes patients with CBD can present with a phenotype or features of PSP. So there is a little bit of phenotypic heterogeneity in these diseases, but you can use these criteria to diagnose. So here is a patient with corticobasal syndrome. So if you see it's the difference from the patient with PSP, here we have an asymmetrical bradykinesia. You can see that the right hand is much more affected. You can see that abnormal posturing of the right upper limb, which is a dystonia. She has bradykinesia and that dystonic posturing in the upper limb. You can also see those little jerky movements especially when she tries to move her hand. There is a myoclonic jerky movements in the hand, and very asymmetrical and stiff. And here we are testing for apraxia. We are asking the patient to show how to salute. She's not able to show. You can ask her how to comb your hand. You can ask to make gestures, which they will not be able to follow to show properly. So these suggest different types of apraxia. So there is apraxia. And then here we are testing for cortical sensory loss. So in this hand, when you write a number, she is able to identify. But in the other hand, when the resident writes a number, she is not able to identify that. So there is a cortical sensory loss in that hand. So this patient has an asymmetrical Parkinsonism with dystonia, asymmetrical rigidity, and myoclonus, along with apraxia and cortical sensory loss, which makes it a probable corticobasal syndrome. And in patients with corticobasal syndrome due to CBD, you will find this type of, you may find these features on MRI, where you see cortical atrophy, especially around the parietal area, which is more on and the it's contralateral to the symptomatic limb. So here we can see that the left parietal cortex seems much more atrophic to the right. So asymmetrical cortical atrophy on MRI. So the other next type of atypical Parkinsonism is multiple system atrophy. This is different from the other two because this is a synucleinopathy. The pathology is a synuclein deposition. And this is characterized by predominantly autonomic dysfunction, bladder, constipation, erectile dysfunction, orthostatic hypotension, along with either Parkinsonism or cerebellar ataxia. So they may have involvement also of the pyramidal tracts, resulting in hyperreflexia, usually have prominent RBD, REM behavioral disorder in sleep, and they may have a jerky myoclonic or a myoclonic postural kinetic tremor. They often have this anterior anticollis, a type of cervical dystonia, and they sometimes develop very early dyskinesias, especially around the mouth when exposed to levodopa. One particular problem in these patients is that nocturnally they may sometimes develop laryngeal dystonia and stridor, which can be life-threatening. So again, there are some criteria for the diagnosis of MSA, which you can read up in these papers. And this here is a patient with multiple system atrophy C. So you can see some nystagmus, gaze-evoked nystagmus here. And when you test for the finger nose testing, it is slightly impaired, especially on the left side. You can see that subtle ataxia. There, when he tries to touch the nose. And if you look at the gait, this is slightly different from the gait that we saw so far. He has a very broad-based and ataxic kind of gait. And along with that, he had significant orthostatic blood pressure fall and urinary incontinence, which makes it probable MSA-C. So in MSA-C, you may find cerebellar atrophy, you may find the middle cerebellar peduncles to be atrophic, and in MSA-P, you may see putaminal rim sign and atrophy in the region of the external capsule. So, and this is another hot cross bund sign, which is also reported in MSA-C. You can see this in the pons, the transverse pontine fibers become prominent, and here's a hot cross bund sign. So the fourth type of degenerative atypical Parkinsonism is dementia with Lewy bodies. This is again a synucleinopathy, which can present with prominent cognitive impairment, and within 1 year of onset of the cognitive impairment, there is Parkinsonism. So these features mimic the dementia that PD patients develop, but PD patients usually develop dementia more than 10 years into the illness, whereas in DLB, this is much early in the first year, dementia with Parkinsonism. So there are criteria again for DLB, the prominent features being cognitive impairment with visual hallucinations and fluctuating cognitive levels, REM behavioral disorders, plus Parkinsonism. And they also have some other features like a very exquisite sensitivity to antipsychotic agents. When antipsychotic agents or dopamine receptor blockers are started for hallucinations, these patients may go into severe Parkinsonism and even neuroleptic malignant syndrome. They also have exquisite sensitivity to levodopa. Levodopa, on the other hand, can worsen the hallucinations and cause dyskinesias in these patients. So those are the degenerative atypical Parkinsonisms. And then we have some other causes of atypical Parkinsonism, like vascular Parkinsonism, which we discussed is the predominant lower body Parkinsonism, which is either an insidious onset progressive syndrome, or sometimes it may be relatively acute onset following a strategic stroke affecting the basal ganglia. And this is often diagnosed apart from the clinical findings, where an MRI may be helpful to show these microangiopathy. You can see these white matter changes in the periventricular region. And these are suggestive of a vascular Parkinsonism. And even in these patients, up to 30% of them may be responsive to levodopa, usually at higher dose. Then we have drug-induced Parkinsonism, which as any clinician, we should be very, very careful about diagnosing in the clinic. These patients present with an acute or subacute onset of Parkinsonism with a temporal correlation with drug use. There are many drugs that can cause Parkinsonism, but these are the very commonly encountered ones, like D2 receptor blockers, including typical and atypical antipsychotics like haloperidol, risperidone, or olanzapine. And these days, very commonly, the D2 blocker used for as a for GI or GERD, levosulpride. Levosulpride very commonly causing Parkinsonism these days. Dopamine depleting drugs like tetrabenazine, and occasionally anti-seizure medications like valproate and phenytoin can also cause that. So this, I always want to share the history of this patient. This is a 58-year-old male who developed a stroke, MCA, right MCA infarct, about 1 year before presenting to us. And this is a relatively small stroke. From this, he recovered to an independently ambulant state over the next 2 to 3 months. But after about 6 months of the stroke, he started developing progressive stiffness and slowness of movements and became wheelchair bound in the 6 months. So you can see the Parkinsonian face, hypomimic, no reduced blink rate, severe bradykinesia of both limbs, and he is on a wheelchair. And this is how he came, and this was the MRI. So if you look at the MRI, very small stroke. We don't expect this much, this small stroke to cause such a severe Parkinsonism. And so we evaluated, and this is the patient after 6 months. So he is off wheelchair. He is almost normally walking, except for that mild reduced arm swing there. So the only intervention that was done for this patient was to stop the levosulpride. So he had been prescribed levosulpride for GERD symptoms, and is very notoriously, especially in patients that now we see with vascular risk factors and strokes, it seems to be causing very severe forms of Parkinsonism. And just stopping this drug, he improved in 6 months. And then there are patients, so far we saw the elderly people presenting or the adults presenting. Sometimes whenever you see a patient with juvenile Parkinsonism, like this 14-year-old boy with abnormal posturing of the upper limbs for the last 2 years, speech disturbance for a year, walking difficulty for 9 months, you can see that Parkinsonian gait. You should look for this eye sign, which is the KF ring, a very beautiful KF ring in the upper cornea of Wilson, suggestive of Wilson's disease. So then there are also a host of other diseases, such as that can cause hereditary Parkinsonism. So this is a 25-year-old male who presented with slowness in activities for the last 3 years, walking disturbances, short steps, imbalance, falls. So an atypical Parkinsonism. And he also then progressively developed abnormal posturing of the left, followed by the right upper limb, and a gradual progression, and became wheelchair bound within 2 years. And here he is trying to do the bradykinesia, upper limb, testing, finger tapping, but unable to do, severe bradykinesia. And he had 2 brothers who passed away with similar symptoms. So we know that there are a lot of red flags here. He's a young male. Age of onset is young. He had early gait, early cognition, a lot of dystonia, became wheelchair bound, and a strong family history. So it's unlikely to be a typical Parkinson's disease. So in such patients, we should always evaluate, and we got an imaging, and this shows mineral deposition. This is showing this SWI blooming in the basal ganglia, in the pallidal region, and in the substantia nigra. So these suggest iron deposition in the brain. And genetic testing revealed a homozygous pathogenic variants in the PLA2G6 gene. So this is a gene associated with the neurodegeneration with brain iron accumulation, a type of NBIA known as PLAN, PLA2G6 associated neurodegeneration. So these are patients whom we say have atypical Parkinsonism. That is, doesn't fit the box for any of the known atypical Parkinsonian syndromes, and they may turn out to have such diseases. So just quickly, what are the investigations that one may do in patient with Parkinsonism to diagnose? First and foremost, it is a clinical diagnosis, and pattern recognition is very important to diagnose this. Levodopa response assessment is very important for us to distinguish whether this is a typical Parkinsonism or an atypical. And neuroimaging may help, as we saw in some of the atypical Parkinsonisms, like vascular Parkinsonism, CBD, MSC. You may see some supportive features, but in PD, it is usually normal. And then functional neuroimaging of the dopaminergic system can help. So in that, you can either do a dopamine PET, DOPA PET, or a dopamine active transporter SPECT. So this is a SPECT scan. You can see this is the normal uptake in the basal ganglia, whereas here you can see there is a reduced uptake in the basal ganglia on this DAT scan, suggestive of presynaptic dopaminergic dysfunction consistent with Parkinson's disease. So this test you may use in certain situations where, there is a patient whom you suspect as having Parkinson's disease versus essential tremor, or in the setting of a very prodromal PD, if you want to diagnose. In the setting of dementia, where we want to know whether this is dementia with Lewy bodies or it is an Alzheimer's disease, or sometimes in drug-induced Parkinsonism, this may help. But in all patients of Parkinson's disease, you don't need to do this test. It is a clinical diagnosis. And you cannot use a TRODAT scan to distinguish between the atypical Parkinsonism syndromes. For that, you can consider a fluorodeoxy glucose PET or an MIBG cardiac scan, which may sometimes help you distinguish between, say, PD and MSA, or for instance. So just to summarize, when a patient presents to your clinic with Parkinsonism, first stage is to establish Parkinsonism by clinically demonstrating bradykinesia with rigidity or rest tremor. Then the next question is to decide whether this is Parkinson's disease or is it atypical. So to say that it is Parkinson's disease, it should have all the typical features and a good levodopa response. So if it is atypical, then we should first look for all these eye signs, vertical gaze palsy, which we saw, postural BP fall, cognition, any cortical sensory loss, any apraxia, any ataxia, and see if it fits into an atypical Parkinsonism. And here also a levodopa response will help you. And then if it doesn't fit into one of the atypical Parkinsonisms, then maybe this is not a degenerative atypical Parkinsonism. Then you think about the drugs, the vascular, these features. And neuroimaging and functional studies may help you achieve a diagnosis in selected patients. So thank you for your patient listening. I'll be happy to answer any questions.
So thank you very much, ma'am, for this wonderful session. I would say that majority of the queries would be solved. I think just listening to this wonderful session. So, am I audible, ma'am?
Yes,
Okay.
yes, I can hear you. Thank you.
So, ma'am, there is one question that has been put there in the chat box by one of the participants that I can see. Is that role of stationary oblique regular cycling in therapy?
Okay, so that's a very important question. So in Parkinson's disease, we just discussed that this is a degenerative disease. So far, we do not have any disease-modifying therapies for Parkinson's disease. All the medications are only to control the symptoms of Parkinson's disease. So one of the interventions that has been shown to slightly slow down the progression of disease is probably physical activity. So patients who are physically active, especially with the moderate intensity aerobic exercises, they tend to progress slowly compared to patients who are inactive. And in terms of progression, in terms of developing gait dysfunction, falls, cognitive impairment, this is definitely slower in patients who are on a regular exercise regimen. So stationary cycle or regular cycling is a good, maybe a good option, because many patients with Parkinson's disease who have difficulty walking don't have difficulty cycling. But it need not be the only option. Patients can also benefit from any goal-directed aerobic activity. So, for example, jogging, swimming, yoga, the Tai Chi. So any goal-directed aerobic activity, generally we recommend at least 30 minutes a day for 5 days a week. That is 150 minutes of moderate exercise throughout the week is found to be beneficial. And this is something, and if the symptoms are, slightly more, they have gait dysfunction or specific problems like freezing of gait, then physiotherapy, good physiotherapy with gait training can help.
Right. Thank you, ma'am. Ma'am, there is another question in the chat box, that is role of propranolol in Parkinson disorders, ma'am.
Yes. Thank you for bringing this. So I didn't discuss the management because that will be another whole lecture on, but I'm happy to take the questions. So propranolol is actually may have a limited role in PD tremor, but generally it is the tremor in Parkinson's disease may usually responds in a majority of patients does respond to levodopa, but it may sometimes require slightly higher doses of levodopa. And it may also respond to medications such as dopamine agonists. And in selected patients, especially young patients with lots of tremor, anticholinergics may sometimes be helpful. So these are the medications that we generally use. But there is also an understanding that the tremor in PD may not be directly related to the dopaminergic. So there are definitely a group of people who don't respond to levodopa. They require higher doses, and even with higher doses, sometimes they don't respond. And these patients are actually sometimes candidates for early surgical interventions like the brain stimulation. But short of that, in such patients, propranolol may be tried, but per se, it is may not be the first line medicine that you would use in Parkinson's disease, as opposed to say something like essential tremor.
So, ma'am, like one doubt that I had, ma'am, like we do DBS here at AIMS New Delhi. So, like, what's the approximate cost that that is like
So
you? Yeah.
cost depends on the type of system that is implanted. So there are various types of DBS implants. So generally now it comes down to there are rechargeable implants and non-rechargeable implants. So not as far as IPG is concerned, so the non-rechargeable implants last for about 4 to 5 years, and the rechargeable ones up to 15 years or more. So currently at AIMS, the cost ranges from somewhere between 6 to 10 lakhs, depending on what is the implant that one opts for.
Right. So thank you very much, ma'am. If like any of the participants they want to ask, they can write their questions in the chat box right now. Okay. So, ma'am, I think yeah. So I would like to invite Professor Ajay Kumar Sood, sir, Assistant Secretary of National Academy of Medical Sciences, for his word of thanks and his comments. Please.
Thank you, Dr. Jaswant. Indeed, it is my great pleasure to thank Dr. Rupa Rajan, the eminent expert for this evening, for making a very comprehensive presentation about Parkinsonism. And in her presentation, she has used clippings for demonstration of science. So we are really grateful to you, madam, for your support to National Academy. I'm very sure that the participants, especially our PG students, have greatly benefited from this presentation, and we look forward for your support in future also.
Thank you, sir.
On behalf of Academy, we are really Professor M.V. Padma Srivastava, ma'am. She is head of the Department of Neurology at All India Institute of Medical Sciences, and she has been supporting this program from the very beginning. I can remember in January and February, she has participated in this Navigate Medico CME program. And first this series, she has kindly agreed to be the chief coordinator, and she has identified the topics as well as the excellent speakers. So we'd like to place on record her contribution to this Navigate Medico CME program. We'll also like to thank our participants, especially our PG students who have attended this session and also asked the question. So once again, I will like to make appeal to all the PG students that please inform your colleagues that these sessions are very, very useful for them, and the eminent experts which are from all over the country will be making a presentation and will be solving their question and queries. And the next session in the series, which is due on next Thursday, that is on 13th of July, is again very interesting session on dementia. And please remember on 15th of July, which happens to be on Saturday, we have another interesting session from Professor Uma Kumar. She's from the Department of Rheumatology, All India Institute of Medical Sciences, and she's going to take the topic of management of rheumatoid arthritis. So please send us your question and queries if you have. So we'll try to convey these to the speaker so that these can be covered during the session. Another information for the PG student is that we have received response from nearly 100 experts from all over the country who have kindly agreed to be NAMS faculty mentor for our PG student. And Mr. Ravi and Mr. Anil, our IT expert, are classifying them into 4 broad categories like medical and allied, surgical and allied, basic sciences, as well as public health. And very soon we are going to place them, their biodata, brief biodata, their interest area and contact details on our website. And they will be happy to sort of be in touch with you online and they will be happy to guide you in your professional career as well as for your clinical competency if you want. So that is another very important component of the Navigate Medico CME program, where we have NAMS faculty mentors available to our PG students online for consultation and advice. So please make use of this facility also. Another point which I want to make, which our secretary, Dr. Kapil, also mentioned, that we have a NAMS newsletter, which is published every bi-monthly. And the next newsletter is due in the month of August. So kindly give us your write-up and send us your write-up based on your experience of this Navigate Medico CME. What are your suggestions for the future and what are your comments? We'll try to incorporate, and also we'll try to publish them in our newsletter. My appeal to all the faculty members who have attended this session, you can also make a contribution, giving suggestion how we can make the CME program as well as the Navigate Medico CME more effective in future. In the end, I would like to thank our IT officers who are helping us in Zoom, recording the Zoom, and also as well on the YouTube, and also sending emails to all the participants, Mr. Ravi and Mr. Anil, who have helped us. And Dr. Jaswant, as Dr. Kapil said, has been always supportive, along with Dr. Preeti from Psychiatry Department of AIMS. So we are really grateful to you for your time and helping us in moderating this session. Your support is really very, very valuable to us. In the end, I would like to thank all the participants and all the PG students who have participated in this program and made this program interesting and interactive. Thanks once again. Thanks to all of you. And over to Dr. Jaswant, please.
Thank you very much, sir. So I think I would like to thank you, ma'am, again, ma'am, for this wonderful lecture. And ma'am, this lecture would be available over YouTube channel of National Academy of Medical Sciences. And I'll also share the link shortly, ma'am. And NAMS, National Academy of Medical Sciences, they will be sharing the link to the participants who couldn't attend today's lecture, maybe due to their clinical duties or any other engagements. So with this, I would like to, we would like to end this session. Thank you. Thank you, everyone.
Thank you.
Thank you, ma'am.